I saw the topic was outpatient management of wounds, and I looked at the curriculum and saw that most of the topics that I personally would cover are being covered. So what I did was I put together a little discussion on what I think is an important issue from a patient healing standpoint, but also medico-legal, and that's the issue of noncompliance. So when we talk about wound healing, the question is, what is the standard of care that you are held to and that you should be offering? And I think there are differences. For example, many of the speakers here are institutionally based. So they have students, they have residents, they have large staffs that can go and do many things that you in private practice may want to do, but you don't have the time to do. And I was going to say, it's a perfect example of that's total contact casting. Anytime I'm in a group with a bunch of podiatrists, I'll say, how many of you treat your average ulcer with total contact casting? And very few hands go up, okay? Whereas if you're in a school or an institution, the number of people that use total contact casting increases. And then we have increasingly industry trying to dictate how you should treat wounds for obvious reasons. And I always tell the residents, you got to remember that industry's first priority is profit. And they answer not to patients, to stockholders. And then if the patient happens to benefit secondarily, that's nice. So they hire thought leaders. They provide educational grants that are supposedly unrestricted, and they're not. And they give you presentations that are more lecture commercials, and they actually try to dictate the standard of care. And I don't think industry should be dictating any standard of care. And this was noted by William Osler over 100 years ago. Over 100 years ago, he said industry had far too much to say about medicine than they probably should, and they create this pseudoscience. They tell you all these wound care products now are going to give you 80, 90% healing rates, and we just know that's just not true. And then you have people that parade up on the dais or write papers that have a good deal of bias, and they either provide dogma or some kind of medical myth. Look at the discussion this morning on using, for example, collagenase for wound debridement. Or whether bioburden really makes a difference, and yet look at all the products you're told to utilize. So this issue of non-adherence to wound care is not only the patient not adhering to protocols, but sometimes it's us. And when non-adherence occurs, there's increased risk for bad outcome. So this could be the patient that's non-adherent, but sometimes we're not adherent to protocols. Sometimes third-party payers will not allow you to provide the wound care you want to provide. There may be a product you wish to utilize, and they deny it. They say, no, we're not going to pay for that. And you're now providing that patient with a second or third choice over your priority. And I think when that happens, you need to put a note in that chart explaining that this patient's being treated less than optimally, in your opinion, because of the decision that's made by the payer, and the patient needs to know that. Sometimes there's institutional regulations. If I go to the hospital, I have to keep up on whose fixation I'm allowed to use, whose fixation I can't use, and of course there's federal regulations. You can't just take out skin graft substitutes, or what's called CAMPs now, and use them without passing through certain requirements. You have to provide 4 weeks for a diabetic ulcer, 6 weeks for a venous ulcer, and so forth. And the cost of noncompliance is significant. So noncompliance could be intentional, it could be willful, and it could be unintentional. Patient may just not understand what you want them to do, but in either case, you've got to watch your education of the patient documentation. And I notice in the literature more and more they discriminate, and they want us to use the word non-adherence rather than non-compliance, because they say compliance. When we say you're not being compliant, we're placing the patient in a subjective position, in an inferior position, and we really want concordance where the patient and family understand what's going on. And then you say compliance with what? Who's making those standards and who's not? So there's the gold standard, which, let's take diabetic ulcers. The gold standard undoubtedly would be total contact casting. but then there's the standard of care, which is how the average podiatrist is actually treating these wounds. And then we have the technologic imperative. You know, we go around exhibit halls, and there's a tendency to want to use the newest and the latest wound care product. And the question is, when you look at these wound care products, you know, who were they used on? And were these really the kind of wounds that you treat? Now, here's an example of an older paper that said it all. So this was looking at 8,611 wound care outpatients, and whether they would have met the requirements to get into a wound care study for a new product. And over 50% would have been excluded because they tell you, well, we're going to study this new product, but in the study, if you had a hemoglobin A1C over this, you can't be in the study. If your creatinine BUN were a certain level, oh no, you can't be in the study. If you're a smoker, you can't be in the study. If you have PAD, you can't be in the study. So they exclude from these studies patients that we're seeing all the time. So how can we be compliant in using these products? And there's high levels of noncompliance. For example, I treat a lot of venous ulcers, and part of that treatment and chronic venous insufficiency is support compression hose. And you could see up to 80% of patients don't wear the compression hose. Now, there may be good reasons. They're hard to get on, they're hard to get off, they can't afford it. But the point is, up to 8 out of 10 patients can't be compliant or aren't compliant. What about wearing diabetic shoes? We know that at best, patients wear diabetic shoes 60% of the time. That's non-compliance, and it's not helpful in achieving prevention of reoccurrence. I mentioned total contact casting, and yet 45% of wound care clinics surveyed don't even offer non-offloading or non-weight bearing of any type, let alone total contact casting, which is not the standard of care. And then sometimes you violate standard of care as a provider because, in your opinion, that individual doesn't qualify. For example, I don't know about you, but I'm reluctant to use a total contact cast in patients that have vascular disease, or if they have clinically significant infection or a heavily exudating wound, or they just have a great big edematous leg for whatever reason, lymphedema, obesity, whatever. I don't want to cast on there rubbing sores. So at times we elect not to follow the standard of care, and we are not adherent, but I think you need to document that because not all diabetics do well, not all venous ulcer patients do well, not all scleroderma ulcers do well. Some of them go poorly, and then you are subject to criticism, possibly even litigation, and they'll find somebody to say, well, I would have put this in a total contact cast, I would have done this, I would have done that. And as I mentioned earlier, even antibiotics you prescribe. On average, patients are taking 62% of the antibiotics you prescribe. So, you know, that's got to be documented and that's got to be watched. And there may be good reasons, there may be bad reasons, but a lot of it comes down to, does the patient understand how important this is? And here's one such study look at the difference between yes and no. You know, how often do you have difficulty remembering to take your antibiotics? It's about 50-50, okay? Forgetting to take them at night. If you start feeling better, do you just arbitrarily stop taking your antibiotics? The answer is yes. These are common noncompliance issues. They tend to pass by us, and you need to evaluate patients, ask about that, and document it. Because if you look at, say, antibiotics as an example, you can see adherence is quite low. And in wound care products, if they're not covered by insurance and sometimes the co-pays and so forth, there's sometimes financial restraints or things like sending patients out with negative pressure therapy, and we tell them, we want you to do this, we want you to do that, pack this wound, then put this cream on it, then do this and that. A lot of times they simply don't have the mental ability to follow complex directions, and so the complexity of the protocol makes a difference. They don't even take their diabetic medicines correctly over half the time. So compliance is a major issue. So of course, like everything else, education's the key, and I think you need to assume that that patient's high risk for noncompliance and do something. Now, when you negotiate with the patient, this is what they look for. They want therapy that they perceive as being tolerable, that they perceive as being reasonable and effective, and allow them to continue their life as best they can. And there's also what's called the social wound. And I know that happens in my office. There are patients that come to my office not to see me. They're going to spend time with my wife. and they're out there talking for a half hour because they have nothing else. They don't have family support. They don't have places to go. And it's not in their interest to heal the wound, because at least if they have a wound, they have some place to go, people to talk to, they get some attention. And I'm not saying it's willful and bad and there's anything nefarious about this, but the fact is there are people that do that. So we have this negotiation that goes on when they're non-compliant. And we say, I'll tell you what, could you offload this half the time? Would you wear your boot when you go out, but around the house, well, and so you're compromising their care when you negotiate this. So documentation, you've got to document that they've been non-adherent. You've got to document that this is how you perceive that non-adherence is affecting their wound care. You've got to document that you've re-educated the patient and warned the patient about the consequences of that non-adherence, and then attempt to correct the problem as best you can. Lastly, I'm going to run a minute over, so I want to say a few words about what's now called social determinants of health. As podiatrists, we're loaded with diabetes, and there's a disproportionate burden of diabetes with racial and ethnic groups, certain minorities and low-income populations, and that makes noncompliance more common. And there's a lot of reasons. I mean, how many times have you heard, my transportation's not available, I couldn't get a ride, I don't have a car, I can't afford that medication? I mean, I have so many patients, I ask them, why aren't you exercising more? They're afraid to go out, fear for their safety. So a lot of these things are realistic issues that we have to confront and deal with. You tell them not to smoke. Again, there's certain racial and ethnic groups that continue to smoke, and when you tell them not to smoke, 2 out of 3 don't, they continue smoking. So this becomes a problem. And marijuana creates the same problem. So smoking has to include that. So they have all these issues that go on. And of course, these patients have more complicating factors. So in summary, poor compliance and adherence is a common factor in delayed and wound healing, no question about it. You need to assess patients for that, because they don't volunteer that they're not doing what you told them to do or ask them to do, and act accordingly. And you've got to watch your documentation, because no matter how you cut it, somehow, as a doctor, you're always responsible for everything. Patients don't have any responsibility whatsoever. And you've got to be careful, and even though you want to always act in the best interest of the patient, you've got to document that. So it goes back to what Sir William Osler said over 100 years ago, when he said, the good physician treats the disease, the great physician treats the patient who has the disease. You've got to know that patient. You've got to know what they're capable of helping you with, what they can't help you with. And as William Osler said, it's much more important to know what sort of patient has the disease than it is to know what sort of disease the patient has. Thank you.